It's now 5:30. I am calling to order the Central Health Board of Managers Strategic Planning Committee meeting. It is Tuesday, February 13th, 2018, 5:30 p.m. We are at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, boardroom. The first item on the agenda is to approve the minutes to the following meeting of the Central Health Board of Managers Strategic Planning Committee meeting, which is December 18th, 2017.
I move that we adopt the minutes for the Central Health Board of Managers Strategic Planning Committee meeting dated as of December 18th, 2017.
Second?
Second.
Any discussion? Hearing none. All those in favor?
Aye.
Opposed? Same sign. Abstaining? Hearing none. It is approved. We'll now move on to the second item on our agenda, which is receive and discuss the Central Health Performance Review conducted by Germain Solutions. And I want to start off by thanking Germain Solutions and welcoming Germain Solutions. We really appreciate the work that you have put into this report, and we think that it is very important to have this type of independent performance review. We want to hear how we can improve, what we're doing that we should maintain, what we're doing an exemplary job on that we should do more of. And I would please ask all of my colleagues on the board to hold any of your comments until Germain has been able to finish the entire presentation. I'd like to now turn the agenda over to our CEO and President, Mike Giesel.
Thank you very much. Members, this is a major milestone in what is a great process for Central Health, and to have an independent review to come in and look at your operations and how you function and to look at your partnerships and is the mark of a great organization when you're wanting to know how do we get better, what do we do better, what directions do we need to think about going. And so tonight what you're going to hear is the work of many months of work from our review organization, Germain Solutions. And again, this is a milestone. This is not the end point. There are many more months and weeks of works ahead. As a quick backdrop, the performance review was commissioned in the spring of 2017, and recall that in prior board books, you've seen strategic work plans where we've organized three what I would call working objectives around how do we deliver care, what kind of care, how do we finance or fund that care. And so you have a framework by which to take what you're going to hear tonight and decide, how do you want to dispose of this? Do you want to change this? Do you want to change a particular strategy? Do you want to look at different ways of funding? And to bring this report and overlay it on top of what is a working strategic plan, you can then get to the point where you will have a refined strategic plan in a few months from now that lines up with a budget. And those two together show the public this is what we're doing with the dollars and how we're taking care of people in Travis County. So I just wanted to give a big picture backdrop to that. There is what I would call an initial management response. It's a memo from myself, but I want to commend the entire executive team for pitching in on short notice to help formulate this response. Again, it is an initial management response. Overall, we concur with the Germain Solutions report. And we offer some other, what I would say, observations for consideration as you're working through this process over the next few months, and then we'll work towards a final set of recommendations. Once the board gives us direction to say, this is what we want to do, then we'll come back with additional recommendations. So this is an initial management response. It's by no means the last one. Before I turn it over to Lisa, Lisa, thank you. This has been a huge undertaking, and while there's a lot of people that, it's a team effort, you bared a heavy burden here over the last several months. And so on behalf of everybody here at Central Health, I want to thank you for your work. And I think at this time, to be appropriate, may we please offer a quick round of applause.
Absolutely.
So with that, I'll turn it over to Lisa.
Okay, well, thank you. I just wanted to introduce our guest and touch base about the engagement. I'll remind you that we engaged Germain Solutions last June after process. And their effort was to conduct a performance review that would evaluate our operational effectiveness and efficiency provide benchmarking comparison to other publicly funded healthcare organizations, and make recommendations about opportunities for performance improvement. So tonight we are going to discuss the performance review of Central Health, the internal assessment in the 6 areas that Jermaine conducted, and benchmarking. And then next week we will discuss the Sendero component at the Budget and Finance meeting. So tonight I want to introduce Tracy Kulik, a partner with Jermaine, and Matt Bowl, who worked on this engagement with us over the past almost year, and turn it over to them to give their presentation.
Hi, thank you for hearing our findings and for the past 6 to 8 months in which you've graciously hosted us and talked to us in quite a bit of detail. We want to open with a few summary remarks. As we get into the presentation, you'll see these themes throughout this performance review. The first one of these remarks is something that may be obvious to all of you, but we have definitely validated that you are among the most complex organizations in the public health sphere in the country. You are uniquely a partnership model, and we found only one entity who had quite a bit of partnering similarities. However, they still own quite a few things. Primarily, most of the other public health and public hospital entities are owned models. And I will tell you, every form of refuge has its price. One of the great things about your complexity is that we feel, and you'll hear this resonate throughout the presentation, that for all of the great dialogue you have, much of which can be conflict or actual, refutation of some of the principles, you are a principle-guided entity. Because you don't own things, you really adhere to what are the principles we stand for. And I think, as Mike already referenced, that is going to be your charge coming out of this, is what is that prioritization of those principles, and how do you determine what is the return on those principles, which may not be as quantitative as you want it to be. But I would say, in a larger impact, what did you do for the health or the social welfare of the people in your area? It is much more meaningful, and it can be quantified in what expenses you didn't incur because of this. Secondly, you're going to see in the report and in some of our findings things that you're already doing, or things that you've already accomplished, or things that you've just started. And I think that's a credit to you as an organization. People typically think, and some of your benchmark people are this, that public health entities move slow. You guys are moving at warp speed, and it probably feels that way to you. But you will see in this short time period, and even though we started mid-June, the assessment really started in August. So many things that we recommended and we thought we were pretty insightful seeing, you've accomplished, or you're 2/3 of the way there. So kudos to you. And I think with that, the third element that we had referenced by Lisa in her introduction was the benchmark component. This study was, like you, complex. Not only did we have to do an internal assessment, which had quantitative and qualitative components, but we benchmarked you against 6 entities in Texas and against 10 nationally. And I want to caution you to not just focus on where you can improve. You're going to see in our findings, you were above average or benchmark in a lot of areas. So take the time to celebrate where you really do well. Some of these may be more qualitative and more principle-minded, like you as a partnership model are, but what we found in the benchmarks, and we're going to be downloading a lot of this to your executive staff for you to peruse as you prioritize things, is that many of them want to know you because they saw you doing things that they have not been able to conquer. So just keep in mind that that's an important part of this also. So given that, we're going to start to go through the presentation.
So we'll go through the basics. This is just a quick agenda for everyone to see. Obviously, we'll cover introductions and sort of have, we'll go into the findings of the performance review, which will be a little bit of process and then on to the findings. We'll talk about the benchmarking process and its entities, and then we'll close with questions and talk about the open email that we've got set up to field responses to our report. So this is just kind of a high-level overview of our methodology. The first thing we did was we got some public input we had focus groups set up. We also had an extensive review of secondary research. We went through a large number of patient surveys that were already existing at Central Health and in large part in community care. We also had interviews. At least Tracy or I or one of our team members interviewed all of you, with the exception, I think, of Mr. Jones there. And so we got your opinion. We've talked to the executive staff. We went and talked to key staff at enterprise partners, affiliated partners, and even some of the contractual partners. So we wanted to get a full 360 view of what your entity is and how it operates. And then we went and started the assessment. There are 6 domains, which we'll cover here in a second, and there are 15 indicators within those domains. So as Tracy mentioned, it's a fairly extensive and robust assessment. And then the benchmarks, 6 Texas public health authorities, and then 10 national hospital districts. And finally, we also have a literature review for those of you who would like to get a little more in-depth into our reading.
In the internal assessment overview, we looked at these 6 domains that Matt talked about. And these domains, which we'll go through some of the findings in detail, and we'll also reference for you where you are benchmark or where other people were benchmark and some of the ways that they achieve that, were communication outreach, planning and finance, that's also planning and budgeting, access, population health, organizational governance, and funds flow.
And we did these are, as we've gone through and done this across the country, these are the areas we found really are impactful for public health and for hospital districts. There are other factors to be sure, but places that excel in these 6 areas tend to be excellent performers in their mission and vision within their communities. The other thing is, once we've got the scoring done, we went to create a sort of a quadrant model. And I call it a quadrant model for a reason, because it's not necessarily a scoring system of 100% is the best and then 25% is the worst. Because there's a component of opportunity that goes with this. And so, and just to give you a brief example, Quadrant A is, you guys are performing high today, but there may be something you could tweak right now that would make it just a little better. Whereas Quadrant B talks about you're a high performer, but this is more of a long-term investment, and leadership and you all as a board need to make a decision, is this something we should invest in for the long term? And it works the same way in the bottom. There are low performance things or things with lower performance that are a near-term opportunity that can be fixed. And then finally in Quadrant D, it's low performance and a longer-term opportunity. And there are not many of them, I will say. These are the ones where you all have to make a decision, is this worth investing in, or maybe it just is what it is? Because you can't, everyone's got limited funds, limited resources, limited time. So we have to be sure that those are worth investing in if you choose to do that. So overall, the assessment, you guys performed as an average above average on the overall assessment. You had a couple of scores in the hundreds of the oversight in particular and district management, which was very impressive. The lowest average ranking was in physician specialty care access. I will say there's one, we'll get into why there's more to that component, but I will say, having talked to the leadership and talked to all of you, specialty care access is not something that you all were unaware that you were, lacking, for lack of a better way to put it. So these weren't new findings, but I wanted to give you a sense of the range. So again, it does go to both extremes.
And you'll see in the benchmarking, only one of your national comparable entities scored high in specialty care access. Right. Throughout the country, this is a sore spot.
It is a systemic problem. There's no question about that. Central Health Partnership, we've talked about it, because you don't operate your own hospital, is very unique among public health districts. We won't belabor the point because Tracy already made it, but I will tell you this is one of the, there's a lot of apples and oranges comparisons, and we did them as best we can, but you don't operate like a lot of other people, so just keep that in mind as we go through this process. And because of your partnership model, you don't always have the ability to fully influence and create transparency within the funds flow to the partner entities. You guys are amazingly good at providing transparency from where it starts with you and through to the partner entities. However, sometimes when you get to the entities and to the end user, there isn't as much transparency that goes on there. And the public, the end user doesn't see what we see when we look at the whole picture. And I think we'll come up with some recommendations in that, but that's a really important thing for note.
Well, the other piece with that, as a partnership model, when you're looking at what influence do you have, you can basically do three things. You can inform the public and your partners, you can influence them, or you can command them. Command is kind of out the window with you because you're a partnership model. The other thing to consider is take, for instance, your partner that you have the most investment in or the most resources you give to, community care. That's 40%. You're not their majority funder. And so influence is probably your strongest input or ability to change decisions. Many of them, it's inform. And so that goes with the partnership model. Now again, every form of refuge has its price. If you own them, you may think you could do more in the command sphere. I would ask you to talk to some of your Texas partners and they would say, oh no, we try. But they have the same kind of issue. And so again, there is merit in always examining the partnership model, not probably as a whole because it embraces who you are and says we want to influence community, health, and social good, but components of it you may want to look at. And you've got some benchmark partners who either divested entities they used to own or now own entities that they used to partner with. So that's something to stay nimble with.
Absolutely. And the other thing, and this is one of the ones we found to be most common in all of our findings, is because of your partnership model, your role, Central Health's role, is often misunderstood or not by the community and the end users that do it. I'll be honest, personally, I was floored because I would come in and talk, and we'd go through a benchmarking process from Delise and others and say, well, I don't see you guys doing this. And she's like, oh, well, we provide money there, or we provide indirect support here, or this. And I was floored to realize how many parts of the community you all touch when it comes to care. But that is very much not translating downstream. And so, one of our recommendations is you guys a little bit, and we'll use Intel Inside. I don't know the reference. There's also for those of you like BASF and some of these other places that talk about, hey, we don't make the product, but we provide the things that make the product go better. Or yeah. Yes, that's this.
They got it better.
That's right. And so that's an important thing for you all to do because, and I mean this in the nicest way possible, if you're going to catch the flack for the things that maybe aren't done well, you should at least get some of the credit for the things you are doing well.
We even had some of your funded partners say this, that they have trouble communicating to their boards or to their clients who Central Health is. And they will talk to them about what initiatives Central Health funded. And they'll be like, well, we didn't put that together. So a branding strategy is one I think that's important for you to embrace. In a lot of your communications, and you guys are incredible with the web-based access to a lot of what you do and how open you are to the public.
Now.
But they have to understand now. But they have to understand who Central Health is to even go to that website. And with that, one of the comments that kept coming up is that it gets too deep too fast, and there isn't an overall branding of we aren't the people who do this, we're the people who make it better. And so that was recurrent theme from even your funded partners.
Absolutely. And I guess number 5, and we talked about this a little bit, we would really like to see a better plan to address the physician shortage issue. Yes, it's systemic across this country. Yes, nobody's got it figured out except for maybe a few choice partners here and there, but I come from a world of graduate medical education. It's got to be a short-term and long-term plan. How can we address physician shortages today? How can we do ancillary support things that will help wait lists and those kind of things? And how do we do it long-term? What are we doing to say we're going to grow the next generation of physicians and we're going to keep them here in Austin? And if that's got to go back to a medical school, if that's got to go back to, or just when they're in residency or all sorts of things. But there's got to be both short and long-term plans because this problem, I'm telling you from going across the country, is only going to get worse. And so If you don't have a plan in place, you're already miles behind. So that's a big recommendation. And
That's
then,
coming from a millennial. He's trying to not say we're aging out.
right. And finally, Central Health should consider exploring opportunities to diversify some of the funding sources. And Tracy can talk a little bit, but philanthropy and grants and those kind of things where you can bring in additional money so there isn't as much reliance on tax dollars.
Now, the caution with this is, with any of these findings, I think the key thing is that step that happens from our review and your strategic planning to that prioritization of what are your core needs and strategies, and only then linking them to another funding source, whether that be federal grants or philanthropy. Because many people's key issue, and I do federal grants all the time, is not to go after just the money, but to be linking that to your priorities. Because they can be also another form of refuge that has its price. You can end up serving the grant instead of the grant serving you. So what's important, and you uniquely do this among the national benchmarks again, is you are very principle focused. And so have those principles drive that entity if you choose to form it, not the other way around.
So, and now we'll go into a little bit on the benchmarking. These are the 6 entities that were benchmarked within Texas. Most of you, I think, are familiar with a lot of these. El Paso, JPS, Parkland, Harris Health, University Health, and Christus Health.
New West is
Nueces, yeah. I struggle to pronounce that. And we also, as we mentioned, benchmarks against the 10 prominent hospital districts from across the country. And we picked these largely because these were the most integrated ones, and it gave you kind of a variety. There's everything from Orlando Health and Palm Beach, who are more similar to you, to places like Cook County and NYC, who are big, old school, basic, care delivery models and systems. So we wanted to give a range, so it wasn't just to give you a full range on the benchmarking.
On the benchmarking findings, we have those really correlated to those 6 domains or categories. So in access, this is one of these areas, and this is when you start to get some of your report card and your gold stars. Access and monitoring access was really uniquely benchmarked to Central Health. Other people monitor pieces of access. They monitor primary care, and as we already stated, only one of the entities, and this is Orlando Health in Florida, has conquered the specialty access issue. That is a recurrent sore spot around the country, and many people are interested in how to fix that one. But you really do look at overall access. Our comments with this would be, on access, you tend to go primary care, specialty care. There is more of a move to go to specific populations access, and particularly minority population access, and we totally, support that movement that you're already making. In planning and budgeting, this is a big strength of yours. Interesting findings here. You are probably the leanest in this area, planning, financing, IT, human resources. Now, having said that, if you're Lisa or Jeff or some of those people, you may say, oh my God, I feel that. And they feel it year round. However, look at it from the flip side, and Mike already imparted this to us. If you're, which you largely are, if you would be to be viewed as a charity, you're returning a lot of money to the community. You look at your Texas comparators or national, you are by far the leanest in this. The only caution I'd give you is you're going to hear in other findings that entities that you have, such as CCC, which has, and Matt will talk about this, a bit of an identity crisis, and the board brought this up. What is CCC? If you move to more of an accountable care organization, you're going to probably strain those already lean resources. So that's a finding that's good and bad in your planning and budgeting, but you are very good at measuring those things and at communicating those to the public. They are not easy concepts to communicate. On communication overall to the public and outreach, you were average compared to your comparable entities, both in Texas and nationally, but overall, the volume of what you do is incredible. A little more focus. Here, what is the priority of that communication and outreach with those strategic priorities? Again, the branding. Pull up. This is like you're going way down in the weeds, and there needs to be more pull up of why are these events important to that particular underserved community or geographic area in Austin, or how does it compare with your overall strategic priorities? But you do a lot of it. And so I think there's the call here to prioritize that communication.
Yeah, and so we go on to the population health, and I know population health has become one of these buzzwords within the healthcare community of we all got to do it, but we're not 100% sure what population health is. But for what it's worth, if you are a hospital district, population health becomes incredibly important to you because a lot of your efforts are going to focus on taking your resources and preventing issues from happening rather than trying to treat the care afterwards because you have limited resources and you're serving a population that already has a fair number of comorbidities to begin with. So the more you can treat those preemptively, then the better off you're going to be. Now for central health, this gets a little tricky because there is responsibilities of central health in terms of population health, and there are responsibilities of the Austin Public Health Department, and those are different things. And that's really important to know. But one of the ways you can kind of help take this split apart is to do what we saw the model from Spartanburg called the key health priorities. And this is what they did was they took 4 or 5 priorities and they put them in everything they did. So the health department had those 5, the health district had those 5, the insurance had those 5, everybody had their 5, and they all tried to align their missions to those 5 priorities. And by the way, Spartanburg won HRSA's award for population health this year under that model. So I think for an organization like you who has so many partners, a unifying message or unifying set of principles would go a long way to helping to align the processes, especially because you have so many moving pieces.
Now we get back to the issue of CCC and what is its role. We heard from some of you, and many in the board shared this. Some of you thought it was an integrated delivery system. And when we said, is that a clinically integrated delivery system? Is that a risk-bearing integrated delivery system? Some people thought it was an accountable care organization and should take on more risk. I think that needs to be decided. This is an entity that could be the population and probably should be one of the population health management unifiers. But there needs to be a definition, a decision, and what resources go into that so that people know what that is. Because when the board itself is got all kinds of varied opinions on what it is, you can see the issues that arise with it. The other piece is one of my favorite ones on Austin. I did a community health needs assessment in 2002 for Austin. And when I came in to some of the providers, they said, oh no, not another needs assessment. They were doing 6 needs assessments at the same time. Now, at the base, there needs to be a mechanism to take the findings of these various needs assessments, some of which are required for not-for-profit entities, some of which are required for certain diseases like Ryan White, other ones which are noble and not required but done, and at least share the findings. We saw common gaps, common barriers, common themes, but there wasn't a real mechanism to share all that. You've done some of that through Central Health with Travis County and with the city of Austin. But then there's these many different partners, many of which are your partners, that some of it's shared, some of it's not. There was even for St. David's 2 different needs assessments done. And so ideally what would happen, and I know this sounds really great, and doing needs assessments, it's really complicated to do, but would be to do joint needs assessments, where you combine, a lot of the questions are the same. Some of the detail could be different, but there would be a good use of resources combined, Sure, it's at different times and serves different masters, but that would be a big effort on the road to population health.
In terms of governance, obviously governance here is a largely prescribed process. You have rules and regulations and charters that have set this up. And so the ability to change it is fairly limited. And that, by the way, that's pretty common nationally and in Texas. But there are small things like potentially implementing term limits that could help bring central health up to contemporary standards. Again, governance was pretty good, but these little things, we noticed people often came back and talked about the lack of flexibility because of the way things operate. This is how it has to be. Okay, and we understand that. But if you can make tweaks here and there that potentially are within the rules to do, there might be some value to bringing it up to contemporary standards, so you don't run into some issues that often happens with boards when they've served for many, many years, and certain people influence boards more than others. And then finally, Central Health's funding is more dependent than most on its tax base, and we mentioned that earlier. But in the same regard, they also get less flow. They also have less dollar flows out to other entities, including the medical schools. So it's probably balances out in the end. But it's interesting how the balance showed up. Right, we were expecting to see more on the funds flow in, but and then the funds flow out also was pretty reasonable. So those are kind of the key.
Well, the other piece with the funds flow is we heard from all of you about wanting to have more of a mechanism to determine a return on investment. What did Central Health invest in entities? What is it getting as a return? There were some areas where that was possible to do, other areas where it was a little murkier, and that could be because it wasn't as well defined of an entity. But even though your return may not, as we already referenced, be as quantitative as, here's money in, here's return out, and some of these things may be more, and to your credit, more savings for what did you do for Austin or Travis County in terms of avoiding unnecessary ED visits, unnecessary hospitalizations, coverage of the uninsured or underinsured. So there's merit even in having, and I know the finance people cringe when I say this, but there's merit in having a qualitative return on investment.
Absolutely.
You can put a number to that as far as what you did for the social good, and that does square with who you are. So I think one of the important things here is, as you're going through an overall performance review, the examined life is worth living. And you are true to who you are as an entity. The fact is, you're unique. You're special as an entity, because when we compare you across other people in Texas or nationally, again, only one, Palm Beach, little bit Orlando Health, has as much partnering as you. They are nowhere near close to you. One of them's maybe 50%, the other 25% partnered. You really are uniquely a partnership model.
I think that's everything.
Okay.
So just to close out, I want to go over the timeline of the steps before we turn it back over to Manager Greenberg.
Yes.
So we will be sharing the report with our partners tomorrow. And get that out there, as well as some information, as Mike shared, as a management response. Next week at Budget and Finance, we will discuss the Sendero component. At the next 3 board meetings, we will also have a dialogue about how we take this and put this work, prioritize any recommendations that we might want. There will be a workshop in March. And then all of this, as you know, will flow into our budgeting process, which begins in April and May. I also wanted to remind everyone that there will be an email address available that will go to Germain Solutions, and that we will collect those questions for the next 3 weeks, and then we will post those responses as well on our website and share that information. So
Thank you.
Back over.
Thank you so much. Thank you, Lisa. Thank you, Jermaine, and thank you all the people who I don't even know about and may not be seen here who have spent many hours working on this. So I want to thank everyone and kudos. And as chair of the Strategic Planning Committee, I want to thank you, Jermaine Solutions, and your sub-consultant, Whitecap Advisors, for this really comprehensive and enlightening performance review and your presentation, which brought out points, and I'm glad you could be here with us because it's so much different to have somebody here in person, and you made comments that I don't think were even brought out in what I've been able to read so far. So thank you. And I know my fellow board members and the Central Health staff are very eager to pore over this report and your findings and determine how we can best use them to develop an implementation plan for this organization, to prioritize, to move forward, and we appreciate that. You know, we started this process last spring, and Jermaine Solutions was selected to lead the performance review after a formal procurement process. You were charged with evaluating Central Health's performance and organizational structure, and the Board of Managers wanted an independent, critical assessment and critical eye on how we, Central Health, are performing in our major functional areas, and comparing that to our peers. As you said, we're apples and oranges, but to the best of the ability, comparing us to our peers and beyond. So I thank you for that. And again, I realize that a lot of work has gone into this, and I appreciate it from everyone. I also want to thank everyone in advance because I know that there's a lot more work that will be going into this, and so thank you very much.
Thank you. Trish, Matt, thanks for all the hard work. I know you got some incredible staff members as well, as Sherry has said. And as a new board chair, like Trish and I talked about earlier, I got the keys to the car. But only because I was a student driver under incredible leadership in the past. You know, with Katrina Downs just led a great board before. And I will tell you that third-party assessment is invaluable. I believe every organization like Central Health should undergo this type of comprehensive performance review by an independent third party. This will help Central Health and the community understand what Central Health does well, where we need to improve, and what opportunities we have to do in the future to even do a better job of creating access to quality care for people in our community with low income. Are we perfect? No. We know we have work to do. This independent perspective will help us refine our key strategies, strategic priorities, and support our core mission. While the work we do is complex, the end game is pretty simple. That's to take care of patients. We want to deliver the best, highest quality health care possible for Travis County. And we want to be the best, most transparent possible stewards of public funds. Again, Trish and Matt, thank you for all your hard work. Thanks for this presentation. I know our executive management team has worked diligently with y'all, and I thank them as well, Jeff and Mike and Lisa and Monica, and I'm leaving somebody else, so I don't want to hurt anybody's feelings, so I'm going to stop it there. But you know, this report is well done. I think this shows our taxpayers. Central Health is doing a good job. We're taking care of those patients who are most vulnerable, our indigent, our poor, our women and children. Everything I've said in the past to you guys. Thank you.
And I think overall, and I know we're going to be delving more into this, but there's a lot that we certainly concur with, and that I know management does, and we look forward to future discussions. We look forward to community discussion. We look forward to staff recommendations, to implementations, and to prioritizing, because our goal is to deliver the best possible care for those who we serve now and will in the future here in Travis County. I do want to emphasize, and I know Lisa mentioned this, that we invite the public to review the report and provide feedback. Tonight, this meeting is being live streamed at centralhealth.net, and it will be posted on our website by noon tomorrow. So thank you, staff. I know you'll be up late working on that. There will be a downloadable copy of the performance review that will be posted on centralhealth.net tomorrow. And the community is welcome to submit questions to Germain Solutions, and this will be posted. It's assessment@germain-solutions.com. I don't expect people to remember that. This will be available to you. And Germain will respond to those questions, and those responses will also be posted on the Central Health website. So as you can see, this is an ongoing effort by everyone. I understand that Central Health staff will distribute the performance review, as Lisa said, to our partners and Travis County commissioners and city council and other stakeholders tomorrow. And at our February 28th Board of Managers meeting, community members will have the opportunity to address the performance review during our citizens communication that we have at the beginning of every one of our board meetings. And during the meeting, the board will discuss the staff analysis of the performance review and their initial thoughts and recommendations, because I know that staff has only just begun to be able to put some thought to this, as all of us have. And we are, as Lisa mentioned, planning a public workshop in March. You'll be hearing more about that. It will be hosted by Central Health staff to prioritize the performance review recommendations and develop an implementation plan. And that's when we'll begin to operationalize the recommendations, to prioritize them, to look at the financial implications as we move into budget season. I know we all can't wait for budget season. So thank you all very much.
Thank you.
May I ask a question?
Absolutely. We're open
With
to Q&A now.
Well, I'm asking you a question just
Certainly.
based on what you just said. With respect to the February 28th meeting, citizens, this is going to be on our website as of tomorrow. People can look at it.
Yes.
But one of the things that we wanted to see was an ability for the public to comment in a meeting, like you said, in March.
Workshop.
But I was curious as to whether the team will be here to be able to respond to questions, since they're the ones that collected the data.
March?
You're the ones, yes, you're the ones that reviewed the data. And if there are public questions, I would think that it would be you all that could best respond to them.
So I think we'll need to get with staff. I know that there was an engagement with Germain, and they're going to be available to answer, I know, questions that come to them online. My understanding is that this workshop in March will be hosted by Central Health staff. I don't think that we've had chance to look at the details, and Mike, if you want to add anything to that, because we really haven't had chance to plan it out.
Well, the reason I'm saying that is because I did make some just perfunctory, is that the correct term?
That's a term. I wouldn't judge it.
Comments, just a quick glance, but there appeared to be an absence of some data to the statements that you made. And so what I was hoping for as a manager here was that you could give us some additional information that would, suggestions, that we might consider incorporating when you tell us, oh, this is a place we can improve. Well, how do you think we can improve? That kind of thing. And so
I'm going to let Mike respond some to this.
So the March workshop is designed to be a pretty robust give and take situation. And I think
the public, right?
With the public, yes, thank you. And yes, this is Germain's report, and there are certain questions that really and truly only Germain could answer, and it depends on how deep the question is. But I think as long as it's a question that, on its face, that the report speaks for itself, then I think we can certainly convey that answer. Now, to get down inside the heads of the reviewers and say, what else did you think? What didn't make it into this report? I mean, ultimately, that's up to them, to be able to respond to that. And so I think it's important, while we have them here, to get as much out as we can in these questions. I'll have to go back and look at the engagement, just to be blunt about it, to see what all we have on contract for subsequent meetings and attendances, and where we are with the budget on this
I
particular
didn't know about
project.
their engagement, yeah.
Well, the other response I would give to that, Cynthia, is tomorrow we're meeting with Lisa and Mike and Jeff, and there's a lot of documentation behind the report. And we are putting together what is that full tab set, if you will.
That's right.
And so,
That's what I had originally asked for. Where will that be? Will it be housed here? Can people look at it? Is it going to be online? It would be like the full work product.
and I think that's our meeting tomorrow morning.
Right, I think once staff has an opportunity to get that full, like, I don't know, if it was a poll, I would say the crosstabs, right? Or that full.
Exactly.
That full set, then they can digest it and see how best to house it. They don't have it yet, so I think tomorrow in that meeting, they'll be able to get it and see from there how to, what's going to be the best process.
I mean, because there's some things that are just evident items that you want. The benchmarking
Right.
people. As you form the strategic priorities, but maybe before you go into the budgeting, you'd want to know who's the contact there.
Right.
Their email, name, phone number. So we've got all that in a tab set, but what we wanted to do was finalize the report with all of you before we pulled all that together.
When do you think that final report will actually be submitted to us?
Well, tomorrow morning, the final report will be submitted, and then we'll meet tomorrow to go through that tab
Staff,
set.
right, to go through all the background material, right?
Okay, and well, then, when we get to the question and answer section, unless this is it, then,
We're open for,
my concern was originally that there were only apparently 20 stakeholder interviews. Is that correct? As according to what was stated here?
No, I mean, it was all
I'm
the,
sorry. Let me find this. I guess look at the report. The number of people that were, the stakeholders that were interviewed.
what we did there was summarize, so we didn't list everyone's names, the Board of Managers and the Central Health Executive
So
staff.
that's-
But there was almost 40 interviews that we conducted through this whole process, because we talked with those 3 levels of partners, your partners who were directly funded, your partners who were affiliates, and your contracted partners. So it was upwards of 40, 45 people that we interviewed.
And so for me, when I'm talking to stakeholders, I'm talking to the public, I'm talking to consumers, I'm talking to patients. That, to me, is a stakeholder. And so, the people who get money from us, are not, they're providers. They're not stakeholders. They have a vested interest. They get money from us. They perform for us. We gauge their success based on their performance. That's what we do. But there's a difference between the two. Provider input, consumer public input, stakeholder input. We all may be stakeholders, but some of us are in this world that rarely gets asked what their issues or concerns or even compliments are. And so when I don't see a lot of that, I'm more concerned about the validity of what I'm hearing other than what exists currently by people who we pay to provide a service to us. So that's my first and foremost concern. And an opportunity to have the public come and
that's what we're planning.
openly come in and provide that.
So a couple
input
things.
is important to me.
Cynthia, you bring up an excellent point and a couple questions. I think I heard you say that you reviewed, of course, confidential and I'm sure in an anonymous fashion, surveys from our clients and our patients.
Yes, we did have one focus group. It wasn't well attended.
Right.
We then worked with people at
Can you tell me how
Central
many
Health
people
and
attended?
Community Care and Seton Family Health Care, and we reviewed over 1,000 surveys. And we went through also all these many flavors of needs assessments.
Right.
And we compiled all those issues. Now, is that secondary research, Cynthia? Yes.
Yes.
I will give that to you. But in the context of what we understood we were engaged for in a performance review, that was our stakeholder input from that. Now, I would say that I think there are many opportunities to take the findings of this report.
And that's what we're going to do with this workshop
And
in
then
March.
do further
Yes.
primary research
Right.
with them. But that's what we used for our stakeholder input.
So
Okay.
Cynthia, we did, so they did review a lot of information from clients and patients, over 1,000. But to your point, and I totally agree with it, we need that robust input from the public, from the community, from all the stakeholders and our various, the various residents who we serve. So that is why we want to start with this workshop in March with the public, with the community.
And so,
I think, and we're going to have to move him to Shannon has a hand up. Did you have another question,
just
Cynthia?
one last one.
Sure, please.
People, you know, we have now, there's about an estimated over 195,000 people of uninsured here in Travis County, even based on the information that you provided to us. The vast majority of those uninsured are going to be in the Latino population. And so one of the things that and the poverty population, okay, those living under, 200% FPL or even under 100% FPL, and may or may not qualify for the various programs that we offer, and so they end up being in self-pay, which is not a comprehensive plan. It's very hit and miss. But how or what was the process for gathering input from people who are outside our realm? And the reason I ask that is because we were talking about creating an opportunity to address the needs of let's say, an area, under the social determinants of health. And we're concerned about the block, but we may only have one or two people on that block who receive our services. So with respect to this, how do we access and bring the people from outside our specific population, those that already know about us, that are receiving service from us, that are hundreds of thousands of people that did not have access to Central Health or to any of our partners? How do we do that?
Well, part of that.
It's like it's in the alternative.
Yeah, part of that answer, I'm going to kind of defer to the budget finance that is to do with Sendero and healthcare coverage. We did address some of that in that part of the assessment, which we're not presenting tonight. That's presented in another meeting.
Right.
But we did get at that through a lot of review of those kinds of surveys, of analysis that we did. We did not do, Cynthia, which is, I know where you're heading.
Right.
More of a needs assessment.
That's
That
right.
was beyond the scope of our.
No,
review.
it's not. It's
So
not
we're-
beyond the needs assessment. It's beyond how do those people who are not participating in our system, what do they think of us? Why are they not participating? To me, it's more important, why are they not participating in our system? Okay, where is the breakdown so that we can best tweak
So I think,
our processes?
I think some of that, and I'm going to go around because I know everyone has questions, but I think some of that I'll address when we get to meet with some of the education initiatives that we've had. Shannon, please.
Okay, as the newbie on the group, I want to commend you.
Welcome.
This is very helpful, and I had the opportunity to read it. And a couple of questions. One is as it relates particularly to the communication to the community. I think there's somewhat
Yeah.
That is what I was
And that's why I
referring
said,
to.
yeah, we'll get to
That's right.
communication.
what Cynthia was saying. Knowing who Central Health is, what it does, how it interacts. And I guess my question is, it's been in existence, 14 years?
Since 2004.
So given that period of time, that speaks volumes in terms of what has and has not been done. I guess my question goes to is, in the models that you've sent me, I think you've said in Florida, a couple of places, are there better systems or strategies to better inculcate that messaging through its partners and to utilize what the partners are doing to inculcate what we're doing? Case in point, there is currently underway, and I don't know if you had the opportunity to know about the CHA-CHIP, the Community Health Assessment. The question goes in, is that a lot of the same information and the data that you're talking about is reflected by the same people who have the same issues. They may not have them with Central Health, but they do have them in terms of health. And so I would encourage you, I'd be interested very much in seeing what some of the findings from some of the partners were in terms of assessing the role of Central Health, its success, and its endeavors to improve. And then the second question I had to ask was particularly this one about the role, the partnership itself. Because being new, I'm not clear myself on a lot of the roles of our partners, particularly the collaborative, what it does, how it operates, and I think that it would be very important to see how the community perceives of that as well. I think that a lot of the success is built on what it is, what it does, how it interacts. And then finally, was any history done in terms of the selection of why the health care model was selected here in the founding days of the district versus the hospital district role? I was actually in the health department when the split occurred, when Gogio at the time was a vendor that came in and helped separate. And part of the development, I never got an answer to, and maybe it's out there, I just haven't seen it, as to what directed to go in the way of the partnership versus the service delivery model. Did you speak to some of this in the report, or is that available?
We did not speak to that history. The other points I can speak to,
And I
but
can
not
speak
that
some
one.
to the history, and so can Mike. Yeah. You want to speak to your points?
Go for it.
Okay. And Mike can speak to this too, but part of that was based because the Central Health, when the voters decided to form Central Health, the situation was that the city itself had already entered into a partnership model. So when Central Health was formed, Central Health, that portion of the tax rate, the property tax rate that the city had to run and operate Brackenridge Hospital, came to Central Health because the city couldn't collect taxes for something it wasn't doing any longer. The assets, the Brackenridge Hospital and those assets then came to Central Health. And Central Health committed to just have the property tax rate be the same as it would be as what the city was assessing for that portion at the time. But the city had already entered into an agreement with Seton.
Daughters of Charity.
The Daughters of Charity, yes.
Right.
To run Brackenridge Hospital. So that was a pre-existing partnership model that was already in the works. And I think, Mike, you can elaborate more on that, can't you?
Well, I'll just a little bit, but then I'm going to look to some folks that, that are also in the room that might have more to add than that. But the way I like to think of it is it literally was a pickup and set down
Exactly, that's what I'm
conveyance
saying.
of everything,
Yes.
and including even the original agreement between the city and Brackenridge Hospital that set up the charity care. piece of it
And
just
Seton, you mean?
picked up- I'm sorry, Seton.
And Seton, yes,
To run Brackenridge, just
Right.
literally picked up everything, just conveyed over. But
right.
in terms of the specifics of the funding, I'd have to look to Jeff or Monica and, throw that out there to see if there's anything that needs to be added to that.
I think it's just, it's evolved since that original, can I call it inheritance?
It was an inheritance of, for instance, that contract with Seton.
Evolved over time, and then one of the other things, and Shannon, you probably know this, is the plan was to convey or transfer over the clinic system also.
Right.
And there was about a 4 or 5 year delay just on HRSA, formally
That's right.
approving the public model of moving it from the city as I think it was a look-alike, FQ look-alike.
Right.
Right, it was, FQHC.
Into a full FQ with this public model, and that took a lot longer than we thought. So that part of it was also just kind of the way, can I say, regulatorily speaking. So there's been you're right, there's been a long history, but it really was a inheritance, so to speak. And then we've just had some iterations of the lease agreements over that time, but nothing real substantial has changed.
I think it's important, though, and thanks for helping me.
And then, well, and then the last piece, of course, is in 2013, we formed the CCC, the Community Care Collaborative, and that's probably the really big event as far as from an entity standpoint, jointly managing the patient care, both on the
ambulatory side and the acute care side.
And what I'm saying is basically, I think it's important to convey that to the community.
Agreed.
Because those who have come in here over the years have no idea. They're not even familiar that Central
That's
Health
right.
is the Travis County
Healthcare district.
Healthcare District.
That it's a government,
Right, so the
Entity.
branding of it, all of that goes a long ways to give legitimacy to what it is we are, and
Right.
what it is we do.
thank you. You had something you were going to address.
To answer your other 2 points, we're going in reverse. We agree in the communications and outreach that the population served haven't been as stratified. It's been a communications that's been overall and more, public health messaging or issues about what services are available, but targeting to specific entities, to Cynthia's point, that aren't being reached or that aren't aware of services or are maybe aware but not accessing them for certain reasons, has not occurred in detail. And that's in process, and that needs to be amped up, no question.
And it just going, it's not just the users. There are people who ask me, what is that section on my tax bill that is for this health care? And I think, and these are people who live in western part of the county more than the eastern. So I think it's important to communicate to them who we are and how that is utilized. So I just want to mention that.
And part of that is on a large scale, it's almost like a bipolar thing here. On a large scale, who is Central Health? And, as I said, even some of your partners have trouble explaining this. And, you are the people who gives the resources to help make things better. But then, in detail, who are these people who are unaware of who Central Health is, that are eligible for these services, that are your target population? How do we get at some of those in detail? And those people who may not be so much eligible users, but want to know who is this entity. I think the other piece is a strong recommendation of ours. CCC has an identity crisis. I mean, people in the board almost equally split between, I think it's an integrated delivery system. What does that mean? Oh, they coordinate care. Well, what does that mean? Do they use care protocols with that? Do those cover across partners? Other people said strongly this is an accountable care organization. It needs to bear risk. That is very different. And I think CCC as a whole is the entity that really needs to be better defined, as to what is that governance given what it is. It could have a strong role either way. There are some great things it's doing. People are largely not that aware of it, and it could be this unifying mechanism, but we heard that even within the board, let alone with other partners being like, I'm not sure who they are.
In the interest of giving everyone time, we'll keep moving. I will say, this is something that I was going to comment on when we came around, but since it's arisen now, one of the great things about having this independent evaluation is to look at, are we on the right road? Are we doing things we need to? Frankly, are our instincts right? And one of the issues was communications. And it was something that, as some of you who are on the board know, I was quite passionate about repeatedly, that I believed that we needed a more robust education initiative so that people would know who we are, what we do, who's part of our enterprise, to have that consistent logo and branding, and to have that education initiative. Staff started working on that some time ago. It was in our budget, but it became live in November and December. And so it's very helpful to have somebody independent look at this and say, you need to be doing that. You're recognizing now we are doing it, and you're saying we should be doing more of that. We'll have to look at budget constraints, but that was very helpful. Maram?
Yes, well, thank you. Appreciate this report. You highlighted that Central Health is unique. There isn't a model nationally that mimics Central Health, so it's very unique and complex. I just want to reiterate that to the public. I want to highlight a couple of points. Internally, the staff, I've actually worked with several people all across, and their heart is for the people. So they're willing to go above and beyond to serve our community and our population that we are responsible for. And given that as well, our heart is for the people. And that's really the focus and the center of everything that we do here on the board and the staff across enterprises. Highlighting a point that Mr. Jones mentioned, talk to the public when I tell like that tax item line. And some of the folks who are in the western sides who actually one of the not the utilizer of our central health are more of the public, and when they know about the work that we do, the social good, they feel good about themselves that they are supporting this entity. And that's something that we are continuing working on branding and talking with the public, which we've started the past few months, and we are hashtag healthcare for all, which I probably would tweak it as health for all, really, because healthcare, as we know, it's only 20% of overall health, and 80% is addressing the social determinants of health, which we will think about it more robust. And we will take this report and we will digest it further and we'll take it into consideration. And we are open, and I appreciate your time, and thank you.
Thank you, Mom. Charles? Anything?
Used to having other board members.
I know.
Yes, sorry. Didn't mean to surprise you.
Your turn.
Your turn.
First of all, I want to agree with what all my colleagues have said. I think it's an excellent report. I look at it as a starting point for us to go forward. And I think the points that you made throughout your presentation, as well as those points that are in the report, are important for us to look at and determine how we're going to go forward with this. But great work. I think, like you said, we need to celebrate a lot of our successes because I think we are a great organization. But as you hear some of the questions and concerns of my fellow board members, we still have some areas where we can improve. And so we need to look at those areas and move forward. But thank you very much. Appreciate it.
Thank you, Abigail.
Hi, thank you for doing this. I have one question, and it's about under the internal assessment part. I spent a lot of time reading this report. Thank you for it. It's very interesting. What I'd really like to understand is under internal assessment, when you talk about aggregation of internal data, do you have a technical supplement, or do you have something that could help us to understand what those internal data are? I would be so interested because I think it's important for us all to see that if you have it and to understand what's available and how that went into the recommendations that you gave, which I think are, it's important we understand with specialty care, for example, where are we falling short, and can we see that, especially for those of us who like data and are into that kind of stuff. I would really appreciate that if you're able to do it.
Well, you have internal assessment. Cynthia has everything. Sherry has the literature review. I mean, we have endless tab sets.
I'm sure you do.
But the benchmarking is another big one.
Right.
And there's a lot of detail in there. So, yes.
So we can have it.
That's what you'll be bringing to the staff tomorrow, is my understanding, correct?
Thank you guys for all this work.
One just qualifier on the CCC comment. To give it credit, it pulls down your disrupt funds like no tomorrow.
Yes, it
So
does.
I wanted not to leave that be a slam on CCC. I think there's huge potential with it, and there's wonderful things it does and can do. It just needs to be better defined, but you're able to pull down a lot of money from that. And that's an important function.
Yes, as they say, show me the money, right? But it is an important function because we know every day our residents face their own challenges in finding health care and in various funding. They have to prioritize in their own lives. And we know that here in Austin and statewide and nationally, it's a continual challenge funding for health care. And so we take that seriously, and we're very appreciative of this information. We look forward to the big stack, and we look forward to further discussions with everyone and to our public discussion and to prioritizing, to seeing how this fits with our principles, as you've mentioned, and of course, back to the money with our budgetary constraints. All right. Anyone else? No? Okay. Well, with that,
Any closing comments?
with
Oh, well, that's the agenda item.
yes, yes. There is one more agenda item, which I will turn to, although it's going to also be a short one because it is, I can get to my agenda, the next meeting. Let me just flip to it. Yep, it is to confirm the next regular strategic planning committee meeting date, time, and location. However, the next regular scheduled Central Health Board of Managers meeting is to be determined because we are working on our schedule for here at Central Health for all of our committees for the year. So it is to be determined. And with that, do I hear a motion?
Hear a motion to adjourn the meeting.
Is there a second? All in favor?
Aye.
Opposed, same sign? Abstaining? All right. We're adjourned. Thank you, everyone.
Thank you, members.